It's 3:15, so I'm going to hand over to Joyoti for the second part of our programme. Thank you.
Thank you, everyone. Hope you're finding it useful. Certainly, I have, even though I think I know quite a lot about peer support. So the second half of our program is really to try and see what initiatives there are out there to provide peer support to sort of underserved groups or those communities that are hard to reach. I want to start off by introducing Maz Ali, who is a kidney transplant recipient, and I looked after him for some time in the pre-dialysis clinic. In 2014, I took over the home therapy service at Heartlands in Birmingham, and we only had about 7% of patients on home dialysis. And the folk around me said, it'll never go up because of the population we serve. And that's a typical clinician thing to say. If you can't get the metrics right, you always blame the patient. So we sought some advice and decided we would get patients to talk to other patients about the benefit of home dialysis. And that's where Maz comes in. He was kind enough, I think, to take this on. So I'm going to let him tell you what he did in Birmingham with the help of Kidney Research UK and some colleagues. Thank you, Maz.
Thank you, Jyoti. Thank you very much for having me. So my name is Maz, and I'm actually a kidney transplant recipient. Next, please, Georgina. Thank you. So it's interesting as a patient to listen to all of these clinicians and talking about the peer support and think it's a new thing. So those of you who don't know, the Expert Patient Programme is a chronic disease self-management course, and it's been around since 1979. It was introduced by Kate Lorig at Stanford University in the USA. She started what's a lay-led structured training program used in patients. Only half of my slides come up. I'm sorry, some of my slides missing. A lay-led structured training program using patients to go out and talk to other patients, which is exactly what we've been talking about today. So originally, back in the day, it started out as a course for people with arthritis. And here in the UK, Arthritis Care took this on board, and they developed a program called Challenging Arthritis, and this was for people living with arthritis here in the UK. The NHS caught wind of this, and obviously, the NHS doesn't like spending money on anything that they don't agree with, and they actually created a generic expert patient program, and this was rolled out in 2002 for people with long-term conditions. So I myself was diagnosed with kidney disease way back in 1990, and I heard about this, and I actually went on the expert patient program myself, and I found it to be really, really beneficial. So much so that I went back and trained as an educator, and then I started delivering the program itself as a 6-week program. You go along once a week for 6 weeks, and they cover lots and lots of different things. And one of them is basically how to manage your condition, not medication. We're not talking medication here today, but the other things that we can do. Next, please. So what we've got in terms of resources out there and the information we have is that people, and I'm sorry if I'm duplicating some of the things that Joyce and Louise have said already, is that people with long-term conditions have similar concerns and problems. So obviously, as clinicians, you're looking at the medical condition, but obviously other things going on in our lives as well as individuals. So not only does a patient have to deal with the health condition, but also the impact it has on their lives and emotions. So speaking personally, I was a full-time manager. I had a really good job going, and Joyce and a colleague said, Maz, your kidney function is deteriorating rapidly, mate. You need to think about dialysis. I'm thinking, me, dialysis? No. I've got young kids at school. I've got other responsibilities. I've got bills to pay, mortgage. I can't give up work. I've got other things to do. If you look at the research that's out there, it suggests that people are more likely to hear and personalize messages and thus to change their attitudes and behaviors if they believe the messenger is similar to them and faces the same concerns and pressures. And we use that when we recruited our peer educators to make sure that the people that came on board actually reflected the needs of, as Joyce said, the hard to reach community, the BAME community in particular. Next, please. So the ACE project was born. Thank you very much to Nida Jane, our leader, as I always call her, from Kidney Research UK. So they came along and they said, look, we need to do something. And Joyce and the team kindly agreed to host this. So what does ACE stand for? Acceptance. First of all, the patient has to accept the fact they have this disease. Okay, it's not a case of if I forget about it and I don't look that way, it'll go away and I'll wake up in the morning and I won't have kidney disease anymore. They need to be made aware of the choices that are available to them. Okay, and the empowerment part was giving them information, okay, in a way that they can understand, and then for them to decide what was the best treatment option for them. So we would start to work with pre-dialysis patients, those that had an eGFR less than 20. So going back to what we said earlier on, using similar patients, we made sure that we recruited peer educators from different backgrounds, different ages, different experiences, PD, HD at home, HD at the clinic, be able to speak different languages. So they were able to engage with the different patients that were coming into our clinics at Hartman's Hospital. So again, using the Stanford University model. So how did we engage with them? So we engaged with them at the patient's home. The renal nurse would make an appointment, and when they went in, a peer educator would go in with them, and the nurse could discuss the clinical aspects, and the peer educator could answer the questions that the nurse couldn't, and obviously talk about their own personal experiences, the lived experiences we've been talking about all afternoon. We were available at the renal clinic, so when the patients came in for the renal clinic to have their bloods and monitored and have their medication, etc., adjusted, there was a peer educator available if somebody wanted to talk to them. Okay. There's a telephone helpline available as well, similar to what Kidney Research UK were doing. And finally, the one I found really, really fulfilling and was really popular with our patients was the Patient Information Day. So a number of things had to be considered when we set this up. First of all, where we were going to invite the patients. There was no point in us inviting the patients to a room at the back of the hospital when the car park was so far away that some people found it really difficult to walk there. Maybe they had problems pushing the wheelchair up their hill. That's Heartlands. So we went for a venue that was in the community, plenty of parking, and it's easy for individuals to come to. Okay. We also had refreshments for them as well. The information days were peer educator led. So the peer educators would talk about the experiences. Somebody with PD would talk about how it's like to have a life in PD. What could they do about going away? So one gentleman, he talks about his holiday to America and how he got machines delivered, etc. Another one who'd been to India, for example. Home hemodialysis, what concerns, what's the pros, what's the cons, and what about the clinic? Okay, what's that like? So we were able to talk from our own personal experiences as to what each of those conditions were and how the treatment options were that were available to us. For the peer educators themselves, similar to what my colleagues have said beforehand, there is fully accredited training provided beforehand to the peer educators to make sure that we're all singing from the same hymn sheet, that we all knew what we're allowed to do, what we're not allowed to do, and where we had to refer patients back to the clinicians, we were able to do that. There was ongoing support for the peer educators simply because obviously it's quite emotional dealing with people who are having obviously issues. For me personally, one of the issues was where people were able to accept the fact that they had kidney failure and then needs to make a decision. I'd had one gentleman who said, no, I'm going off to Pakistan. I know there's other treatment options out there that don't involve kidney machines and needles and all the rest of it. And that was discouraging. And what we found was that there was a lasting effect of the project, both on the patients and the renal staff too. So like some of your colleagues on the call today, thinking, well, why are we doing this? What's the purpose of this? Not another project. I'm busy enough as it is. I've got all these other things to do. So we had a couple of staff, I'm not mentioning any names, Joyce, who were concerned about the fact that they've taken on another project. But I was happy to say that afterwards, they actually saw the benefits of it and the difference it made to the patients. Next slide, please. So some of the benefits that we found, and again, most of you will say, well, can you prove this? Have you done stats and surveys? And we need a lot of money for that. So I'll leave that to yourself, the clinicians to do. I'm talking to the patient, somebody's a peer educator who spoke to patients and delivered the patient training days. So first of all, it actually enabled patients to decide on the dialysis options that are best for them based on their own personal needs, their lifestyle, their family choices, etc. So they became aware of the choice available and empowered to make a decision based on that. And as Joyce said, there's an uptake of patients going on to home dialysis, and there's still that benefit, that ripple effect seen even now after our ACE project ended. And more importantly, both for the clinicians on the team and for the patients themselves, there was an increase in the trust between the patients and the NHS team, which is great news, which is what you want. You want your patients to be able to trust you, not to be thinking, is what they're saying right for me? Do they know what's going on in my background? Do they understand what my own concerns are? And going forward, we found there's the trust built a better relationship for the journey ahead. So obviously, if somebody was on dialysis, they may well later on need a kidney transplant, obviously, and they want to have that trust with the clinicians and be able to talk to them openly. Next, please. This is our original network of teams. That's our very first patient education and training day. So we were very fortunate that our local fire station has a community room that they give out free of charge. And that's where we held the very first event. But unfortunately, it wasn't big enough for us. So after that, we had to go and get a bigger room. Thank you very much for your time. Thank you.
Thank you, Maz. I'm just going to add in a few things as the clinician who is leading this. There's lots of nervousness about actually exposing patients to patients because it hadn't been, we had the expert patient program for diabetes in our centre, but this hadn't been done before. And I suppose one of the things that I tend to do is just, say, let's just do it and see how it happens. And all the fears dispelled within the first few weeks when actually the nursing staff that lead the education program found that their job was much easier because patients were actually listening, to somebody who looked like them and somebody who probably lived in the same community. The second thing is moving the education out of the hospital really did help because we used to hold our education days on a Friday. Which is the day when most of our patients who are Muslim will go and pray. And then we wondered about why there was poor attendance. And I think the third thing was that we started believing that actually we could offer home dialysis to our patients. So within a year of starting this program, our home dialysis grew up to 13% from 7%. And then it's continued to grow. We're sitting at about 25%. And I'm pleased to say we're no longer at the bottom half of the West Midlands hospitals that offer home dialysis. And like Maz says, the ripple effect is all continued. And we still get in touch with Maz and his colleagues to say, we've got really difficult to reach patient, can you help support? So that's from my point of view, certainly was a success. My only regret is that we were not able to sustain it because of the lack of funding once the money for this sort of time-limited project ran out. Maz, you stuck to time beautifully. You're ahead of schedule. There is a Q&A built in, so happy to take any questions before we move on to the next one. Or if you're happy to stay, Maz, then we'll carry on with the other three presentations.
Carry on. Yeah, I'm happy to stay. Yeah.